Thanks for inviting me and my colleagues to present our study on cognitive dysfunction in patients with advanced cancer, which focuses on the impact cognitive dysfunction may have on existential values, meaning in life, and interpersonal relations. Here, my colleagues are mentioned, and our disclosure. Both researchers and clinicians struggle in regard to understand and assess cognitive dysfunction among patients with cancer. Studies show that medical treatment, including chemotherapy and the use of opioids, together with the stressful experience of being diagnosed with cancer, can lead to a decline in cognitive function. Studies suggest that up to 70% of all cancer patients are suffering from mild forms of cognitive dysfunction. And even these sudden changes can have an impact on existential well-being of the patient and their relatives, as cognitive functions are vital for the patient's ability to cope with the illness, as well as understand and participate in treatment decisions. Also, cognitive functions like memory, attention, concentration, psychomotor coordination, and so on are highly related to our sense of self. Therefore, we anticipate that experiencing changes in cognitive function can influence the existential well-being of the patient and their relatives. This hypothesis leads us to ask the following questions. What associations can be identified between objective measures of cognitive dysfunction and reports of cognitive interference in everyday life? And how may cognitive dysfunction be related to existential concerns that influence existential well-being? To answer our research questions, we designed a mixed method study consisting of 5 neuropsychological tests assessing the following cognitive domains: sustained attention, psychomotor speed, attention concentration, mental flexibility, and global cognitive function. These were being tested in the validation study conducted by Professor Sjøgren and PhD Geana Kurita, with the aim to validate whether different neuropsychological tests could be applied within palliative care. In connecting to this, we did the interviews. And the interview setting was the following. 3 days after being tested, both relatives and patients were involved in the qualitative part of the study. Here we conducted in-depth and semi-structured interviews, drawing on the descriptive phenomenological tradition. The interview guide covered personal background, experiences of cognitive dysfunction, including existential concerns influenced by the cognitive change and its impact on everyday life. In addition, questions were asked about existential values and the abilities to practice them. This interview was repeated about 3 months after the test took place to hear about whether the informants experienced further change in regard to cognitive function. We then performed a thematic analysis of the interviews to be able to compare the objective measures with the experience of cognitive dysfunction related to important life domains that the patients and relatives connected to the practice of existential values. 13 participants that were patients in treatment of the section of palliative medicine at the University Hospital in Copenhagen, and 11 of the relatives were recruited in connection with their participation in the validation study. The sample sought to ensure a diversity in terms of gender, age, education, and cancer diagnosis, as you may see here. They all gave written informed consent before the interview. Along the neuropsychological tests, we obtained 47 interviews with both patients and relatives. I will now present the results from comparing the objective measures with the analysis of the subjective experiences of cognitive dysfunction. The agreement between the subjective experience of cognitive dysfunction and objective measures were found by comparing the cutoffs of the neuropsychological tests with the patient's report of problems within the specific cognitive domain covered by the test, and then compared with the relatives' impressions. An example of agreement is when patients with poor cognitive performance on the sustained attention test also reported difficulties to keep focus on long conversations, or when patients who performed well in the cognitive test did not mention issues in the related cognitive domain. The percentage number of patients that obtained agreement was calculated and can be seen at the bottom of the schedule. We found cognitive deficits in 12 patients, which had an agreement between 85 to 100% for most of the objective measures and subjective experience. The cognitive test relating to psychomotor speed was only showing 31 of agreement between the subjective experience and the objective measure. The green marking indicates non-agreement, where the informants perceived a problem that could not be found objectively, and the yellow marking, where the patients did not report a problem in this specific cognitive domain. When extracting the themes from the description of the subjective experiences of cognitive dysfunction, we identified three major areas that were interlinked. One, the existential concerns related to cognitive dysfunction in everyday life. Two, social adjustments to cognitive change. And three, alteration of self-perception influencing existential well-being. We found that the experience of cognitive dysfunction had an influence on the practice of existential values and thereby inflicted patients' and relatives' existential well-being. The informants reported that cognitive dysfunction challenged the practice of existential values in relation to three main fields: friends and family, work, and physical activities. In connection to the social life domain, an informant expressed how the cognitive dysfunction could cause distress and make it difficult to practice existential value. As today we had to pick up the grandchildren, and even though it was at 1:30 and the clock was only 12, I started saying, "Now, can we be there on time? And we only have to go from here to there." So some things like that make me feel very stressed. It's simply the overview I'm missing and the sense of time. In regard to feeling the impact of the cognitive dysfunction in the life domain related to work, one informant stated how this is experienced as a loss of something valuable. "Well, I made a living from coordinating campaigns for a big company where everything needed to be coordinated with all stores, and I had to be the link for 40 people. It's hard to lose this competence and realize that you can barely coordinate things at home." The existential values that were practiced through everyday activities in the different life domains could also be challenged in the connection to physical activity. Here one informant explains how being physically active is highly important to her. "I was waking up 3 times a week, and this is what I miss the most." Tackling a lower level of physical activity also in relation to household chores makes her exclaim, "Oh, in fact, I am extremely disappointed with the last part of my life. I really am. I did not expect this." When the cognitive dysfunction interfered with everyday activities, it seemed to cause existential concerns when important aspects of life became threatened. Reporting on the same cognitive dysfunction as the patient experienced, relatives confirmed the impact that the change had on their shared life. The shared experience of cognitive dysfunction influenced the relationship between the patient and the relative. One relative describes how the cognitive dysfunction changed their everyday life and interaction. "Now, it has become my job and my responsibility that our everyday life is as good as possible." The cognitive change seemed to impact both the patient and the relative's existential well-being. When one patient explained it, she said that her existential well-being was influenced by the alteration of how she was perceived. "It is a change of our life. I was the one who was able to remember everything, and now one can't count on me anymore." All relatives confirmed the experience of cognitive dysfunction and stressed the importance of taking over cognitive or practical activities to maintain the ability to practice common existential values. When both succeeded adjusting to the cognitive dysfunction, existential well-being could be preserved. So in conclusion, we found a high agreement between subjective experiences of cognitive dysfunction and objective neuropsychological measures. We found also that cognitive dysfunction challenges practicing existential values, and that could lead to existential concerns. And furthermore, that existential well-being of both patient and relative is influenced by this cognitive dysfunction, but that could also be adjusted for. So here we find the references, and I would like to thank you for your attention.